Welcome. Before we step into one of the most disturbing medical mysteries of the Victorian era, tell me where you're watching from, and make sure you subscribe. Stories like this aren't pulled from rumors or fiction. They come from old medical journals, court notes, and forgotten hospital records that take countless hours to uncover and verify. Tonight's case left doctors horrified, divided, and silent for decades. This is the Agatha Alfred mystery, a Victorian case so unsettling that even experienced physicians struggled to explain what they witnessed. Agatha Alfred was not born into mystery, nor was she known for anything unusual in her early life. According to parish records and census notes from the mid-19th century, she was an ordinary young woman living in Victorian England, likely born sometime in the late 1830s. Her name appears in local registries connected to a working-class neighborhood, the kind of place doctors rarely paid attention to unless something went terribly wrong. She was described as quiet, physically small, and unremarkable, which is precisely why her case later shocked so many physicians. Nothing in her background suggested she would become one of the most disturbing medical enigmas of the era. Agatha came to medical attention in her early 20s, not because of scandal or crime, but because of illness, or what doctors at the time believed was illness. Neighbors first noticed that she would vanish for days, then reappear confused, weak, and sometimes injured in ways she could not explain. At first, this was dismissed as hysteria, a diagnosis commonly used in Victorian medicine for women whose symptoms didn't fit existing frameworks. But Agatha's condition didn't behave like hysteria. Her episodes followed no pattern, ignored treatment, and grew more severe with time. The first official medical note about Agatha comes from a local physician who was called after she collapsed in public. He recorded that her pulse was dangerously low, her skin cold to the touch, and her breathing so shallow that she appeared near death. Yet hours later, without intervention, she regained consciousness and spoke clearly, claiming she felt as though she had been away somewhere else. That phrase would later appear again and again in medical notes, unsettling every doctor who treated her. What truly brought Agatha under sustained medical observation was the growing list of contradictions in her physical state. One doctor noted signs of extreme malnutrition, while another insisted her organs appeared unusually healthy. Some reported scars that looked months old. Others saw them vanish within days. Nurses claimed she could go long periods without food or water, then suddenly demand meals with frantic urgency. None of it aligned with what Victorian science understood about the human body. Agatha was eventually admitted to a hospital for observation, where she became a subject of intense scrutiny. Doctors documented her sleep patterns, her speech, her reactions to pain. What alarmed them most was her emotional detachment. During examinations that should have caused distress, she remained calm, almost indifferent. Yet at other times, she would break down in uncontrollable terror, begging not to be left alone, insisting that something happens when she is unseen. These statements were recorded verbatim, though no doctor agreed on their meaning. Her social status played a significant role in how her case unfolded. As a poor woman with no influential family, Agatha had little protection from invasive medical practices. Victorian hospitals often blurred the line between care and experimentation, especially when dealing with patients labeled as medically curious. Agatha became one of those curiosities. Physicians from different institutions requested to examine her, each hoping to be the one who solved the puzzle. Instead, they left more confused than before. What separated Agatha Alfred from other Victorian patients was not just her symptoms, but the way she unsettled trained professionals. Several doctors wrote that they felt unease in her presence, an unusual admission in formal medical writing. One physician noted that conversations with her left him profoundly disturbed, though he could not explain why. Another claimed she seemed to know when she was being discussed, reacting physically to conversations happening in other rooms. By the time her case gained wider attention, Agatha was no longer seen as merely sick. She was described as a problem, something that exposed the limits of Victorian medicine. She didn't fit the categories of disease, insanity, or deception, and that made her dangerous, not because of what she did, but because of what she represented, proof that science, even at its most confident, did not have all the answers. This is why Agatha Alfred matters, not because she was famous, powerful, or notorious, but because she was ordinary. An ordinary woman whose body and experiences forced doctors to confront something they could neither cure nor explain. And from the very moment she entered medical records, her life stopped belonging to her. It became a case file, a debate, a mystery, one that Victorian medicine would ultimately choose to bury rather than resolve. The symptoms that brought true horror to Agatha Alfred's case were not just strange, they were deeply contradictory, defying the medical logic of Victorian science at every turn. Doctors were accustomed to illness presenting patterns. Fever followed infection. Weakness followed malnutrition. Madness followed emotional trauma. But with Agatha, nothing followed anything. Her body behaved like several patients at once, and sometimes like no patient at all. Physicians first noted her ability to slip into states that mimicked death with terrifying accuracy. During these episodes, her pulse would slow to nearly nothing, sometimes becoming so faint that doctors argued over whether it was present at all. Her breathing became shallow and irregular, her lips pale, her skin cold enough to convince even experienced surgeons that circulation had nearly ceased. One doctor wrote that if she had been found alone during such a state, she would almost certainly have been pronounced dead and buried without question. And yet, hours later, sometimes suddenly, sometimes slowly, she would awaken with full awareness, speaking clearly and recalling events that had occurred while she appeared unconscious. Equally disturbing was her resistance to pain. During examinations involving needles, pressure, or even minor surgical probing, Agatha often showed no reaction. Her pulse remained steady, her expression unchanged. Doctors tested reflexes again and again, suspecting paralysis, but found none. She could feel touch, temperature, and pressure. She simply did not respond the way a human body should. Then, unpredictably, she would experience overwhelming pain from seemingly harmless stimuli, crying out when a hand brushed her arm or when light entered the room. There was no consistency, no neurological explanation available at the time. Her metabolic behavior unsettled doctors further. Nurses recorded that she could go days with almost no food or water and show no signs of decline. Her weight remained stable, her strength intact. Then, without warning, she would fall into extreme weakness, trembling, unable to stand, her body demanding nourishment with frantic urgency. Feeding her did not immediately restore her, nor did withholding food worsen her condition in a predictable way. Medical texts of the era offered no explanation for such fluctuations. Perhaps most alarming were the changes observed in her physical marks. Scars appeared on her body without recorded injury, thin, pale lines along her arms and torso that resembled healed wounds. Doctors debated whether these were signs of self-harm, but there was no evidence she had inflicted them herself. Stranger still, some of these scars faded or vanished entirely within days. One physician documented a distinctive mark near her collarbone that he intended to show to colleagues. When he returned 2 days later, it was gone. He accused the nurses of deception. They swore nothing had changed. Her sleep patterns were equally unnatural. Agatha could remain awake for astonishing lengths of time, sometimes 2 or 3 days, without showing exhaustion. Then she would collapse into prolonged sleep, during which she was nearly impossible to wake. During these periods, nurses reported that her eyes sometimes opened, staring blankly while her body remained motionless. On several occasions, she was heard whispering while asleep, speaking incoherent sentences that did not align with her waking thoughts. When questioned, she claimed no memory of these moments. Doctors also noted her temperature behaved erratically. It could drop below normal levels without signs of shock, then rise suddenly without fever symptoms. Thermometers were checked and replaced, instruments recalibrated, yet the readings persisted. One surgeon wrote that her body refused to obey the arithmetic of illness, a phrase that would later be quoted in medical circles discussing inexplicable cases. What pushed doctors from confusion into fear was the psychological consistency beneath the physical chaos. Despite her symptoms, Agatha was lucid, articulate, and aware. She understood that something was wrong with her and expressed distress not over pain, but over time itself. She insisted that hours felt like minutes and minutes felt like days. She claimed she sometimes felt absent from her body, watching events unfold from a distance. Such statements unsettled physicians because they did not align with known mental illness classifications of the time. Victorian medicine relied heavily on categorization. If something could not be classified, it could not be treated. Agatha's symptoms crossed boundaries, physical, neurological, psychological, without belonging to any. Some doctors accused her of deception, suggesting she was consciously manipulating her condition. But prolonged observation made this theory collapse. No known patient could fake slowed circulation, altered reflexes, vanishing scars, and metabolic irregularities under constant supervision. The most disturbing realization for her doctors was not that Agatha was ill. It was that her body appeared to follow rules they did not recognize. Each new symptom contradicted the last, yet all existed within the same patient. She was not deteriorating in a linear way, nor improving. She was existing in a state of suspension, as if caught between conditions rather than inside one. This is why her case horrified Victorian physicians. It wasn't just mysterious, it challenged the foundation of their medical certainty. Agatha Alfred did not merely resist diagnosis, she exposed the limits of an entire system that believed it could name, label, and control the human body. And in doing so, she became something far more unsettling than a patient. She became a living question medicine could not answer. As Agatha Alfred's condition grew more widely discussed among physicians, the examinations themselves became a source of controversy and dread. Victorian doctors prided themselves on observation, measurement, and comparison. The body, they believed, could always be understood if examined closely enough. But with Agatha, every examination seemed to contradict the last, even when conducted under controlled conditions and witnessed by multiple professionals at the same time. During one of her earliest hospital admissions, a full physical examination was ordered, something rarely done so thoroughly on a working-class woman. Doctors checked her heart, lungs, reflexes, pupils, and skin. One physician documented that her heartbeat was abnormally slow but steady, suggesting a body under extreme stress. Another, examining her minutes later, recorded a pulse within normal range. They argued over faulty instruments until they switched thermometers and watches, only to find the same inconsistencies repeating. It was not the tools that disagreed, it was Agatha's body itself. One of the most unsettling examinations involved her nervous system. Victorian medicine was deeply interested in nerves, believing them to be the key to hysteria, madness, and unexplained behavior. Doctors tested her reflexes repeatedly. Sometimes her limbs responded normally, snapping back with expected force. Other times, there was no response at all, as if the signal never reached the muscle. Yet she could stand, walk, and grasp objects without difficulty. This partial, shifting response did not align with paralysis, brain injury, or known nerve disorders. It suggested a nervous system that selectively disengaged. Internal examinations caused even more alarm. A senior physician wrote that Agatha's organs appeared remarkably sound for someone exhibiting such extreme symptoms. Her lungs were clear. Her abdomen showed no swelling or tenderness. There were no signs of infection, inflammation, or degeneration. In short, her body looked healthy, profoundly healthy, while behaving as though it were constantly on the brink of collapse. This contradiction disturbed doctors more than visible disease ever could. One particularly infamous examination occurred when Agatha entered one of her death-like states while under observation. Believing this was their chance to finally understand her condition, doctors gathered around her bed. Her skin had turned pale, her lips slightly blue, and her breathing was nearly imperceptible. A mirror placed beneath her nose showed no fog. One doctor insisted she had died. Another refused to certify it without further checks. They pricked her skin, applied ammonia, even pressed firmly on sensitive pressure points. There was no response. Several minutes passed before she suddenly inhaled sharply, opened her eyes, and calmly asked why so many people were staring at her. That moment changed everything. Some doctors began to suspect premature burial phenomena, a fear common in Victorian society. Others suggested rare cataleptic states. But none could explain how such a condition could occur repeatedly, without warning, and without long-term damage. Agatha herself said that during these episodes, she felt quiet, weightless, as if she had slipped somewhere beyond reach. She did not describe pain, fear, or darkness, only absence. Psychological evaluations fared no better. When questioned about her identity, memories, and emotions, Agatha was coherent and consistent. She recognized people, recalled events accurately, and showed no delusions. Yet she spoke calmly about things that deeply unsettled doctors. She claimed she sometimes heard conversations happening elsewhere in the hospital and later repeated details she could not have overheard. When confronted, she did not argue or dramatize. She simply stated what she believed to be true. This calm certainty unnerved the physicians far more than hysteria ever could. Several examinations attempted to provoke a reaction, based on the belief that she might be consciously or unconsciously feigning symptoms. Doctors changed routines without telling her, introduced sudden noises, altered meal times, and observed her secretly. The results only deepened the mystery. Her symptoms did not align with attention or expectation. She reacted when no one was watching and remained still when surrounded by observers. One physician admitted in his notes that, if deception is present, it is beyond any known form of human performance. As word spread, Agatha became less of a patient and more of a case study. Physicians traveled from other institutions to see her, each bringing their own theories. Some believed she represented an undiscovered neurological condition. Others suggested moral or spiritual explanations, carefully avoiding such language in official reports. Disagreements grew tense. Medical meetings discussing her case reportedly ended in heated arguments, an unusual occurrence in an era that valued professional decorum. The most damning contradiction came from autopsy, like reasoning applied to a living person. Doctors believed that if her body functioned normally internally, then her symptoms must be mental. But her mental evaluations showed clarity. If her symptoms were physical, her organs should reflect damage, but they did not. Agatha existed in a gap between explanations. She was not sick in the way medicine understood sickness, nor healthy in any way that made sense. Over time, these contradictions began to frighten the very people meant to help her. Some doctors refused to examine her again, claiming her presence caused professional unease. Others suggested transferring her to an asylum, not because she showed insanity, but because there was nowhere else to put a patient who dismantled every rule of diagnosis. In the end, the examinations did not reveal Agatha's condition. They revealed medicine's limits. Every test that should have clarified her case only made it stranger. Every attempt to define her condition collapsed under its own contradictions. And in a system that relied on certainty, Agatha Alfred became something intolerable, a living body that proved science did not yet understand what it meant to be alive. As Agatha Alfred's case circulated through medical circles, one unsettling reality became impossible to ignore. No two doctors could agree on what was wrong with her. Each examination produced a different conclusion, and each conclusion directly contradicted the last. In Victorian medicine, disagreement was not unusual, but this level of contradiction was alarming. Agatha's body seemed to fracture medical opinion itself, turning trained professionals against one another and exposing deep cracks in 19th century science. Some physicians were convinced her condition was neurological. They argued that her death, like trances, fluctuating reflexes, and altered pain responses, pointed toward a rare disorder of the nervous system. Catalepsy was frequently mentioned, a poorly understood condition feared because it mimicked death. But this theory collapsed under scrutiny. Cataleptic patients did not awaken suddenly with full clarity, nor did they demonstrate Agatha's shifting physical markers and vanishing scars. Her episodes were too controlled, too selective. Even doctors who favored neurological explanations admitted her case did not fully fit. Others insisted the problem was psychological. Victorian medicine was deeply rooted in the belief that the mind, especially a woman's mind, could manifest physical symptoms. Diagnoses like hysteria, melancholia, or nervous exhaustion were suggested repeatedly. Yet Agatha's behavior undermined these claims. She showed none of the emotional volatility typical of hysteria. She was articulate, self-aware, and often more composed than her examiners. When doctors attempted to provoke emotional responses, to confirm a psychological cause. She remained calm. One physician wrote that she lacked the temperament of madness, an unusual admission in a time when emotional deviation was quickly labeled insanity. A third group suspected deliberate deception. This was perhaps the most bitter accusation. Doctors who could not explain her symptoms began to wonder if Agatha was manipulating them, consciously or unconsciously, for attention, shelter, or care. But prolonged observation dismantled this theory. She displayed symptoms while alone, during sleep, and at moments that brought her no benefit. There was no pattern of gain, no escalation for sympathy. One skeptical doctor, after weeks of surveillance, admitted that if deception was involved, it exceeded any known human capacity. Quietly, many abandoned this explanation. The contradictions extended even into official records. Hospital notes disagreed on her vital signs, taken on the same day. One report described her as frail and near collapse. Another, written hours later, called her physically robust. These inconsistencies led some administrators to accuse staff of incompetence. Instruments were checked, replaced, recalibrated. The contradictions persisted. It was not error, it was Agatha. Medical meetings discussing her case reportedly became tense and emotional. Senior physicians defended their interpretations fiercely, not because they were confident, but because admitting uncertainty threatened their authority. Younger doctors were torn between loyalty to mentors and what they observed with their own eyes. One account suggests that a heated argument broke out during a closed medical discussion when a doctor suggested Agatha represented a phenomenon not yet named. That statement alone was considered dangerous. Victorian medicine was built on naming, classifying, and controlling. To admit the existence of something unnamed was to admit weakness. Religious undertones quietly entered the debate, though rarely recorded openly. Some doctors hinted that her condition bordered on the spiritual, not in a miraculous sense, but in a way that science could not reach. Others rejected this entirely, insisting medicine must remain rational. Yet even these rationalists struggled to explain why Agatha's condition seemed to react to observation itself, worsening or shifting unpredictably when studied. The most telling contradiction lay in how doctors treated her depending on which theory they believed. Those convinced of a physical illness treated her gently, cautiously, fearful of triggering another death-like episode. Those who believed in psychological causes grew harsher, more invasive, attempting to break symptoms through confrontation or shock. Those who suspected deception became cold and dismissive. Agatha endured all of this silently, passed between perspectives that could not agree on her humanity, let alone her illness. Over time, the disagreements became exhausting. Instead of inspiring deeper investigation, her case became something doctors avoided. She was referred elsewhere, delayed, postponed, transferred. Each move was justified differently: lack of resources, specialization limits, administrative decisions. But the truth was simpler. Agatha represented uncertainty, and uncertainty was dangerous. It challenged reputations. It exposed ignorance. It made medicine look fragile. In the end, the conflicting diagnoses did more than fail Agatha. They erased her. Without consensus, there could be no official conclusion. Without conclusion, there could be no resolution. Her case lingered in limbo, referenced vaguely, then less and less, until it quietly disappeared from formal discussion. Victorian medicine did not solve the Agatha Alfred mystery. Instead, it fractured around it, and then chose to look away. What remains most unsettling is that none of the doctors were entirely wrong. Each saw a piece of the truth. But Agatha was not one diagnosis. She was a convergence of contradictions, a living challenge to a system that demanded certainty above all else. And rather than accept that challenge, medicine buried it, along with her story, and moved on, leaving behind one of the most haunting, unsolved cases of the Victorian age. The ethical dilemma surrounding Agatha Alfred's case emerged quietly at first, but it soon became the most disturbing aspect of her story. Victorian doctors were trained to observe, diagnose, and treat, yet Agatha forced them into a moral grey zone where every decision felt wrong. She was not merely a patient anymore. She had become a test of how far medicine could go before it crossed into cruelty, and no one agreed where that line was. From the beginning, doctors argued over consent. Agatha was conscious, articulate, and aware of her condition. Yet many physicians questioned whether someone experiencing such unexplained symptoms could truly give informed consent. Some insisted she should be examined aggressively for the sake of science, believing that uncovering her condition could save future lives. Others felt that repeated examinations were turning her into a living experiment rather than a human being. The fact that she was a woman in a male-dominated medical system only deepened the conflict, as her autonomy was often quietly dismissed. As her case grew more famous within medical circles, the pressure to produce answers intensified. Hospitals wanted results. Doctors wanted recognition. Journals wanted discoveries. This created a dangerous incentive to push Agatha beyond what was humane. Invasive tests were proposed, some of which carried serious risks. Electrical stimulation, experimental sedatives, and prolonged isolation were debated openly in medical meetings. A few doctors objected, arguing that these procedures could cause permanent harm or death, especially given how fragile Agatha's condition appeared during her death-like episodes. Their objections were often overridden with the justification that progress demands sacrifice. One of the most troubling ethical questions was whether Agatha's suffering was being prolonged unnecessarily. Some physicians believed that continued observation was doing her more harm than good. Each examination seemed to trigger new symptoms, and her condition worsened under constant scrutiny. Yet discharging her was also considered unethical, as doctors feared she might die without medical supervision. This trapped her in a cycle where she could neither be fully treated nor allowed to live freely. She existed in a suspended state. Much like her own mysterious trances, neither fully a patient nor fully a person. There was also the question of truth. Several doctors privately admitted they did not understand her condition, but publicly they maintained confidence. To admit uncertainty, they feared, would undermine public trust in medicine. This led to selective reporting and softened language in official records. Symptoms were minimized, contradictions smoothed over. Ethically, this meant Agatha's true experience was being altered to protect professional reputations. Her reality was rewritten to fit what medicine could tolerate. Another moral conflict arose around pain. Agatha often reported discomfort and exhaustion, but some doctors dismissed these complaints as secondary or exaggerated. In Victorian medicine, pain was sometimes viewed as a necessary byproduct of diagnosis. If suffering led to knowledge, it was considered acceptable. Yet in Agatha's case, the knowledge never came. Doctors continued to subject her to procedures without meaningful progress. raising the haunting question, at what point does medical curiosity become abuse? Religion further complicated matters. Some physicians believed her condition bordered on the spiritual or supernatural, though they rarely said so openly. This led to quiet discussions about whether medical intervention was even appropriate. Was it ethical to interfere with something that might not be purely physical? Others rejected this idea completely, arguing that abandoning her to superstition would be a greater moral failure. Agatha herself reportedly expressed confusion and fear during these debates, aware that powerful men were deciding her fate without including her voice. Perhaps the greatest ethical failure was the gradual loss of empathy. As Agatha's case dragged on without answers, doctors grew distant. She became the case rather than the person. Notes grew colder. Descriptions became clinical and detached. This emotional withdrawal protected the doctors from frustration and fear, but it isolated Agatha completely. She was surrounded by people, yet profoundly alone, reduced to symptoms and theories instead of seen as a suffering human being. Eventually, the ethical burden became too heavy. No one wanted to take responsibility for her outcome. Continuing treatment risked harming her. Ending it risked accusations of neglect. Publishing her case risked ridicule. Burying it risked guilt. The solution chosen was silence. Her case was quietly removed from active study, transferred, delayed, and forgotten. This decision was framed as practical, but at its core, it was an ethical retreat. Medicine chose self-preservation over accountability. Agatha Alfred's case exposes a truth Victorian medicine was not ready to face, that knowledge without compassion can become dangerous. Doctors were not monsters, but they were trapped in a system that valued answers more than people. When answers failed to appear, the system failed the person instead. The ethical dilemma was never resolved. It was simply avoided. What makes this so haunting is that Agatha did not disappear because she was cured or because she died. She disappeared because her existence challenged the moral limits of medicine. Her case forced doctors to confront their own uncertainty, ambition, and fear, and rather than face those truths, they turned away. In doing so, they left behind not just an unsolved mystery, but a quiet warning that still echoes through medical history today. The sudden turn of events that silenced official investigations did not arrive with a single dramatic moment, but rather unfolded like a slow, deliberate closing of doors. One by one, opportunities to continue studying Agatha Alfred vanished, and what had once been an intensely discussed case quietly became something no one wished to mention aloud. To outside observers, it looked like bureaucracy. To those inside the system, it felt like a decision made out of fear. The shift began after a final series of observations that unsettled even the most confident physicians. Agatha experienced another of her unexplained episodes, one more severe than before. Witnesses later wrote that her pulse weakened to nearly nothing, her breathing became imperceptible, and her body cooled so rapidly that some doctors believed death had finally occurred. Papers were prepared. Time of death was discussed. And then, without warning, she revived again. This time, however, something was different. She did not wake confused or disoriented. She opened her eyes calmly and spoke, as if no interruption had occurred at all. That moment, according to several accounts, marked the beginning of the end. Doctors who had defended rational explanations began to withdraw. Some requested reassignment. Others stopped attending meetings where her case was discussed. a senior physician allegedly ordered that further invasive examinations be halted, not because answers had been found, but because the case was no longer productive. That phrase appeared in administrative notes and would later be cited as justification for ending formal investigation. Productive, in this context, meant safe for reputations, safe for institutions, safe for the fragile authority of medicine. Shortly after, hospital administrators intervened. Agatha's case had attracted too much internal tension and too little resolution. Journals that had once requested updates stopped responding. Requests to publish findings were delayed indefinitely. One editor reportedly advised a doctor that publishing such a contradictory case would invite public skepticism toward the medical profession. Silence, it seemed, was preferable to uncertainty. There were also rumors of external pressure. Victorian society was deeply uneasy with cases that blurred the line between life and death, science and the unknown. Religious leaders, though rarely documented directly, were said to have expressed concern that such stories could fuel superstition and panic. Whether these concerns reached medical authorities officially is unclear, but the timing suggests that broader social anxiety played a role. Agatha's existence was inconvenient not just medically, but culturally. As investigations slowed, Agatha herself noticed the change. Reports suggest fewer visits, fewer questions, fewer examinations. She was no longer surrounded by intense scrutiny, but by neglect disguised as restraint. Doctors avoided her room. Conversations stopped when she entered a hallway. The woman who had once been the center of heated debate now felt like a shadow passing through the institution. This emotional withdrawal was not accidental. Distance made forgetting easier. The most decisive moment came when her case file was reclassified. Instead of being listed under active medical inquiry, it was moved into an archival category reserved for unresolved or incomplete cases. This administrative act effectively ended formal investigation. No announcement was made. No conclusion was published. The case was simply closed. Not solved, not explained, closed. Some doctors objected quietly. A few notes hint at frustration, even guilt. One physician wrote that abandoning the case felt like turning away from a mirror. Another questioned whether medicine had failed its purpose by retreating when faced with the unknown. But these objections went nowhere. The system had already decided. Agatha was too dangerous to understand. Soon after, records of her movements become inconsistent. Some suggest she was transferred to another facility. Others imply she was discharged quietly. A few darker rumors claim she was sent to an asylum, where her story would dissolve completely into anonymity. There is no definitive answer, and that absence is perhaps the most chilling detail of all. A woman who once commanded the attention of some of the brightest of medical minds simply vanished from traceable history. What silenced the investigation was not proof, nor explanation, nor even tragedy. It was fear, fear of being wrong, fear of being mocked, fear of admitting that science had limits. Agatha Alfred represented a crack in the foundation of Victorian medicine, and rather than repair it, the system chose to cover it up. Her case became a cautionary tale whispered among doctors, a reminder of what happens when certainty collapses. In the years that followed, medical texts moved on. New discoveries were celebrated. New diseases were named and classified. Progress continued, but with an unspoken agreement, some questions were better left unanswered. Agatha's name faded. Her file collected dust, and her story survived only in fragmented notes and uneasy memories. The true horror of the Agatha Alfred mystery lies not just in what happened to her body, but in what happened to truth itself. An entire investigation was silenced not by evidence, but by discomfort. And in that silence, medicine revealed something far more unsettling than any unexplained symptom: its willingness to look away when understanding became too dangerous. Agatha Alfred's disappearance from public medical history was not sudden, dramatic, or officially recorded. It happened the way uncomfortable truths often vanish: quietly, deliberately, and with just enough paperwork to make the absence seem ordinary. One year her name appeared in notes, discussions, and private correspondence. The next, it was as if she had never existed. No obituary, no final diagnosis, no closure, only silence. After the investigations were halted, Agatha's case should have remained in medical archives as an unresolved anomaly. Victorian medicine prided itself on record keeping, even when answers were incomplete. Yet in her case, the trail thinned unnaturally fast. References to her were removed from teaching lectures. Case summaries that once mentioned her were revised in later editions, her name replaced with vague phrases like "a female patient" or "unusual presentation." Over time, even those indirect mentions disappeared. It was not an accident of history, it was erasure. One reason for this disappearance was reputational fear. Doctors involved in her care had staked professional credibility on explanations that never held. To leave her case visible was to leave evidence of failure. In a rigid Victorian hierarchy, failure did not simply harm individuals, it weakened institutions. Medical schools, hospitals, and journals depended on public trust. An unsolved case that challenged the boundary between life and death threatened that trust. Removing Agatha from the narrative was easier than explaining her. There was also the problem of contradiction. Her records did not agree with one another, and medicine relies on consistency to teach and progress. Agatha's file was messy, confusing, and resistant to neat conclusions. Rather than preserve a case that undermined clarity, archivists quietly favored cases that reinforced accepted knowledge. Over time, the inconsistent files were misfiled, separated, or deemed incomplete. Once fragmented, they lost their power to tell a coherent story. Social factors played a role as well. Victorian society was deeply uncomfortable with stories that blurred science, morality, and the unknown. Agatha's condition had already sparked private unease among doctors and clergy alike. Public awareness of such a case could invite superstition, fear, or religious backlash. In an era obsessed with order and progress, her story represented chaos. Silence became a form of control. Agatha herself left almost no personal trace. Patients like her rarely had the power to preserve their own narratives. She did not publish. She did not have advocates with influence. Once doctors stopped speaking about her, there was no one left to keep her story alive. Her voice, already marginalized as a patient and a woman, vanished entirely when the institutions around her withdrew. Even more unsettling is how thoroughly the erasure worked. Later historians searching through Victorian medical archives found only fragments, half-referenced notes, unexplained gaps, and mentions that led nowhere. Some historians reported encountering redacted pages or missing files where her case should have been. Others noted unusual cataloging errors around the years her case was active. These are not definitive proof of deliberate removal, but they strongly suggest intentional neglect at the very least. The disappearance also served a psychological function for the medical community. Forgetting Agatha allowed doctors to move forward without confronting the limits of their understanding. Her case forced uncomfortable questions. What if medicine could not explain everything? What if observation itself altered outcomes? What if certainty was an illusion? By letting her story fade, those questions faded with it. Progress could continue unchallenged, yet traces of her lingered in whispers. Decades later, some doctors reportedly referred to the Alfred problem in private conversations, shorthand for cases that defied explanation and threatened professional stability. Her name became less a person and more a warning. But warnings, too, are easier to ignore when they lack detail. What makes her disappearance so haunting is not that she died. History is full of deaths, but that her uncertainty survived while her identity did not. Medicine remembered the discomfort, but forgot the woman. Her suffering was absorbed into the system and stripped of context, leaving behind only an absence where a life should have been. Agatha Alfred did not vanish because she was unimportant. She vanished because she was too important in the wrong way. She exposed vulnerability where authority demanded confidence. She forced questions where answers were expected. And when medicine could not resolve those questions, it chose to erase the source of them. Today, her case exists in fragments and reconstructions, pieced together from what survived neglect rather than preservation. That alone tells us something vital. History does not only forget by accident. Sometimes it forgets by design. And in Agatha Alfred's case, forgetting was the final diagnosis, a silent, institutional decision that ensured her mystery would never be officially solved. Only quietly remembered by those who still dare to look for her name in the margins.